To the third day of our meeting, our regional meeting 2023. We have had fantastic 2 days and look forward to another fantastic third day. Having had discussions yesterday on new issues around new STI diagnostics and preventive agents, and issues around priority groups and substance abuse, on early inclusion of pregnant and breastfeeding people in research, and the whole discussions around gender diverse populations, and the final, what really for me was a wonderful panel discussion, looking at different ways of how we could achieve our goals in HIV prevention and close the gaps that still exist. And I think one other fantastic innovation was the new science generation sessions. And I really look forward to the leadership looking at those concepts and seeing as to which ones amongst those can move forward and drive the HPTN research agenda forward. And I know for a fact there were a lot of people who worked hard, and really we would look forward to leadership giving us feedback actually on those concepts. And so to today, I do hope that we shall continue to very, very vigorously be interactive as we have been in this meeting. Wafa will continue the moderation of the session this morning, and this afternoon, the Cabotegra group, where's the Cab LA group? They still remain over there, so we'll continue with them this afternoon. So welcome again to day 3, and let's settle down and participate in this forum. Thank you.
Well, thank you very much, and warm welcome to everyone on the third day of the meeting. And I also echo the enthusiasm that was just expressed, and of course applaud everyone for their engagement with the conference and with the concept generation and all the other activities. We have an exciting morning with several presentations, and the plan is that each of our presenters will speak for about 25 minutes or so, 20 to 25 minutes. 15. Okay, I've just cut it down to 15 minutes, I hope. Okay, so that we can have some discussion and questions and answers, and offer some discussion afterwards. I'm going to present all of the speakers, and then we'll start the presentation. So for starters, very happy to welcome as our first speaker, Dr. Kenneth Ngure, who's an associate professor and chair of the Department of Community Health at Jomo Kenyatta University of Agriculture and Technology in Nairobi, Kenya. And he's also an affiliate associate professor at the University of Washington. And he's also an elected member of the Governing Council of IAS. Congratulations, representing Africa. And he also sits on the executive board of IAS. He's going to be talking about the Matrix network, which is focusing on development of innovative HIV prevention products. And then it'll be followed by our very own Nyaradzo Mgodi. Welcome, Nyaradzo, who is going to be giving us a talk on the future of bNAbs for HIV prevention. All of us know very well Nyaradzo, and as you know, she's a member of the HPTN Executive Committee, and she's also protocol co-chair of the AMP study, and many, many other studies that she's played a key leadership role here in the HPTN. She's, of course, an investigator at the University of Zimbabwe, at the Harare, in Harare, Zimbabwe. And then we're going to have a pre-recorded presentation by Dr. Gesine Meyer-Rath, and who's going to be talking about practicalities of accelerating access to HIV prevention products, something that we're all quite concerned about and interested in. And she's a a research associate professor in the Department of Global Health at Boston University. And she's also a principal researcher in the Health Economics and Epidemiology Research Office, which is situated at WITS here in South Africa. And then last but not least, we'll have Lucilla Blankenberg, who's going to be talking to us about the impact of media on public health messaging. And she's the director of Community Media Trust, CMT, based in Cape Town. It's a nonprofit organization that specializes in HIV and other health media outreach and training. And I think it's going to be very interesting to hear about her work, as it's quite relevant to our efforts in terms of advancing HIV prevention, and certainly in terms of advancing correct information and knowledge about HIV prevention products. So without further ado, I'm going to invite Dr. Ngure to give the first presentation, and we'll go sequentially, and then we'll take questions. So, keep track of your questions, and then we'll try to address them after the presentations. Thank you.
Thank you very much, Dr. Wafa. I think this is a great morning to start talking about developing the next generation of HIV prevention products for women and what we are doing under Matrix. And I'll then spend the next 15 minutes, and would have been happier with 20, but we'll squeeze in with 15. So as a key takeaways, just to mention that Matrix is supporting development of 9 products. We have some placebo studies that are starting soon, and phase 1 studies, and that's Matrix 001 that is looking at TAF EBG insert, Matrix 002 that's looking at the film, but for this one we'll be looking at the placebo, then the placebo dual prevention monthly ring, and Matrix 003. The other thing that I would want to highlight is that in Matrix we're doing some innovative approaches. Some of them having the design to delivery, where we are talking to end users to get feedback before the products are actually developed, sort of being like a core design process. We're also talking to business, market dynamics, and commercialization hub, where we are thinking about issues of costs of delivery, and thinking of how we can think about scale up even before the product is developed. And then another key innovation and a key takeaway message is that in Matrix, we are also developing capacity and a case, so that eventually some of these products could be developed in sub-Saharan Africa. So we are not only having an innovative products, but we also have an innovative name, and which is Matrix, which stands for Microbicide Research and Development to advance HIV prevention technologies through responsive and innovative and excellence. So Matrix is a 5-year funded project that's running from December 2021. We are starting our 3rd year in December 2023. And we are looking at product developers. So we are bringing in the product developers, behavioral scientists, and people to think about the marketing issues, and also to develop capacity. And it's led by Dr. Sharon Heria and Dr. Tess Parani, who could not join us today. So in terms of goals, we are working and thinking through developing products through North and South partnership, products that are acceptable, mainly to end users, acceptable to stakeholders like male partners, health providers, and regulators, affordable, meaning that products that you could be able to stretch the efficacy window so that people come to the clinics for fewer times, products that are dual purpose, meaning that they don't have to make multiple visits, products that are scalable when we are thinking about issues of stability of the API, and deliverable, we are talking about to ministries of health to start the issues before we even start delivering these products. And we talk to end users, and they will be able to meet the end users' needs, such as prevention of pregnancy and HIV. So Matrix is structured in 5 hubs. There's the Technology Accelerator Hub that has a scientific advisory group that guides the various products, which products go to start with the placebo, which starts with phase 1, which products go to phase 2. And then we also have the Clinical Trials Hub that is going to lead this development of these clinical trials and guide the implementation of these trials. Then the Design to Delivery Hub, where I'm heavily involved. And in this, we are research, we have 3 pillars or 2 pillars. One pillar is on talking to end users and other stakeholders who are not within the clinical trials to just get their initial reactions when they see the products. What would they want about the products? And then we are also having a pillar 2, which is talking to end users during the delivery of the product, when they see the ring, when they insert the ring, and then they will tell us, they will give feedback, and which will improve product development and delivery. And then we'll also talk to stakeholders. And then the back is another pillar, which is very important. Again, as I said earlier, thinking about the costing issues, and then the capacity strengthening. And we have 4 product developers, starting with Conrad, Oakcrest, Population Council, and University of Pittsburgh, Mgodi Women's Institute. So when the product portfolio within Matrix can be broadly categorized into 4. We are those products that are dual purpose. There are those products that are designed to provide protection for 6 to 12 months. There are those products, the vaginal products that are the ring and the film that take about a month. And then the product that would be used at each use when you're like end user kind of products that you can use around the time of sex. And most of these products have not yet been tested in clinical trials, but there are some APIs that you may find that you know very well. And now, so going to each of the products, I will highlight what the product is. One of them is the TAF EVG, which is a fast dissolving insert, which is developed by Conrad. And this can work for up to 3 days. And this is a product that's highest well developed, that's going to get into phase 1 trials, probably this year, because we've, like in Kenya, we've already received our approvals. Then we have the Gesine fast dissolving insert. Gesine is a product that is well known. It's from C. algae. It's a protein from C. algae, but is now being bioengineered, and works very innovatively because it binds to GP120 and prevents it from binding to HIV core receptors. Again, we know the product, but now it's the delivery that's going to be packaged as an insert that can be used 4 to 8 hours, but has been shown to have effect with even up to 12 hours. And then these 3 lower APIs we are most familiar with, that's the dapivirine as a ring, but here we will change it into a film, and this will be a monthly film, and that could work for about a month. And then we also have cabotegravir hydrogel depot. Okay, yeah. It's a double, okay, yeah. So depot, and depot is just a burst, it's a sort of a bulb that's a bubble that can go IM or under the skin and releases drug for up to 6 months. Yeah, and then we have the dissolving pellets, cabotegravir pellets, and these are pellets that can be used for 6 to 12 months. And these, again, these 2, the cabotegravir products, are being developed by Conrad, and they are products that we know the cabotegravir with just the stretch of duration, and they could either go again under the skin, like the popular contraception. And then all these 3 products could also have you could add RNG to make it do a purpose. And then the other innovative product is a non-ALV, non-hormonal ring that's being developed by Oakcrest, and it has an anti-HIV antiviral, meaning that it's the issues of resistance or necessitating testing very so often may be avoided. And then have a non-hormonal contraceptive, and that's a very innovative contraceptive, because most of the common contraceptives work on the women's hormonal system, but this one sort of destabilizes the movement of the sperm. And it's, again, very interesting product. And then the 3, as I said, do a purpose. So we'll start with the TAF EVG, and it's called the Wicked Special because it's a product that can be used on demand. And I know many of us who are, even the Linda Chibada, who yesterday we had a lot of time spending discussing around the young women, challenges we face with young women, because they're not able to predict that they're going to have sex or to plan their lives. So this is a product that can be used by addressing girls and young women. It's highly discreet, portable. And the good thing is also, because it's a local acting, it doesn't not much gets into the system. And as I said, can be used on demand. And we have also been able to see that there have been activity around HSV2, but the thing is for this funding, we are only looking at HIV and HIV specifically for this one. So the HSV would probably be looked at in the future. And then, so why were we thinking about this? Again, we do not have any on-demand product for women. We only have on-demand PrEP for MSM. So this is going to be the first on-demand product. And then fewer side effects because it's a local acting. And then we may have additional benefits with the HSV2. And this is a product that is well known because there are some trials that have looked into it, like the Conrad 146 and MTN 039. But this has been on shorter duration, 1 or 2 inserts in the rectal compartment, on the vaginal compartment, like in Conrad 146. But for this one, we are going to use it for a longer period. So it's going to be for 3 days, data for 3 days, and then each alternate day for another 14 days. And we'll be looking at issues of acceptability and safety. So this is the specific trial that's being conducted in 3 clinical trial sites. And I'm happy to mention that the protocol co-chair, Rira Mansu, is in the audience. And we will be looking at issues of both safety and acceptability. And it's going to be done or to start very soon, not October, probably November or December. And it's going to be looking at these issues of acceptability and safety, and also additionally in African women. So again, repeating, just talking about looking at again the issues of safety when used frequently, and not extending to African women, not in the US, and looking at how long this product stays in each of the compartments, how long it stays, especially in the vaginal compartment, and which other compartments does this drug go to. And we should then, this will inform us whether to go to phase 2 studies. And then we move a bit faster when we think about the vaginal fumes. Again, vaginal fumes are fairly new to many people. One of the key things is they're easy to use and private, just like the ring. But the good thing is that they will not require to be removed. They're also low cost, easy to manufacture, and safe with no messiness. And this is a picture of just how the fume will work. It can easily be inserted when the woman is sitting, squatting, or stepping on a seat, and it will dissolve within a month. And this is the matrix 002, and the protocol co-chair is with us, Dr. Nyaradzo, and this will be looking at a placebo film, because you want to make sure that it's the right film that goes to phase 1. Yeah? And we have 2 shapes. We have the C shape with the circular edges, and we have a shape with the square edges. And the reason we want to test these 2 shapes is that the square edges one, when we presented it to stakeholders, they thought, especially from Kenya and South Africa, they thought that it would not be very easy to insert, but whereas Quattro was done like in Zimbabwe, we didn't have a lot of concerns, but it is also more easier and cheaper to manufacture a square shape. And so we want to know which shape, especially when they experience it. And we'll also answer several questions around whether they want it and which shape that they would prefer. And if they can insert it themselves, there are various ways of inserting. When we give the placebo film to the women, they try to wrap it around their finger. We don't encourage that. We want it folded and inserted so that it doesn't stick to their fingers. And we'll look at all these other questions. Then the only addition is that here is that we have had fumes evaluated, the 7-day fume evaluated in the US, and we had also a quick dissolving placebo fume in South Africa. And so we want to know whether the fume will be accepted before we add the drug, the dapivirine, on. And then the one ring, again, this is a ring by Ocrest, which already has going to have an antiviral compartment drug and also a contraceptive drug. It's been demonstrated safety in sheep, and the antiviral activity has been demonstrated in mice, and the ring is already designed and it's moving forward. And this is the shape of the ring, and it's going to be done in 003. And we have one of the co-chairs of this protocol, Surena Reddy, and It's going to be designed to deliver the two products, and even in future, product that you could probably switch off, because one compartment is the contraceptive, the other one is anti-HIV. You could probably in future start this adult, but for this trial, it's going to be fixed and probably in the coming trials. And we'll collect data from the 003 about how this, the safety of this ring. We'll be looking at any local side effects. We'll be looking at any concerns around the resistance, and then we'll be looking at issues of pregnancy. And remember that this ring is a monthly ring, and we're also testing the firmness. As we look at this ring, they're going to have two rings. So they'll use one ring for 1 month, and before they shift to the other one after a washout period, and we'll be looking at what is preferred in terms of the ring firmness. The size of this ring is the same size as the dapivirine ring. The only addition is the 2 cassettes. And then these products have not yet are not yet moving to trials this year, probably in some time next year. That is the carb imprintable pellets, carb depot, and the grifts in fast dissolving insert. So stay tuned for these trials, and if you see our readership in Matrix, keep and asking for the updates. So we would want to thank and acknowledge all the funders and the institutions listed here. So thank you.
Thank you for speaking to exactly 15 minutes. So we're moving next to Nyaradzo. Welcome, Nyaradzo.
How do I get the slides? Sure. So good morning, everyone, and thank you, Wafa. Thank you to the leadership for having me present on behalf of a village. This discipline of broadly neutralizing antibodies is really done by a village. So I'm privileged to be presenting on the future of broadly neutralizing antibodies for HIV prevention. And today I'll talk about the road to combo AMP. So okay, the timer is mistimed, so if they could sort it out. So my presentation outlines is Ngure started about talking about the future. So today is really about back to the future. So what is the future of bNAbs in terms of HIV prevention? We know that antibodies are safe and effective in preventing many infections, yeah? And we know that bNAbs are safe, tolerable, and they can prevent HIV, and this came from the AMP. I didn't want to be outdone by the carbotegravir table. I think we've got multiple AMP tables here. So we did show that bNAbs are safe, tolerable, and can prevent HIV, and a combination of bNAbs may be needed to increase or prevention efficacy. So we are in the process of conducting trials, phase 1 trials of combo bNAbs, hoping to inform the development of combo AMP. So we've talked throughout since Wednesday, we've been talking about the HIV pre-exposure prophylaxis. We talked about approved products, and Ken Ngure here, he's just been talking about investigational products. So we know that among the approved products, we've got oral pre-exposure prophylaxis, we've got topical, the dapivirine vaginal ring, we've got parenteral, we've got the, I'm going to call it the Landowitz-Delany-Morefe carbotegravir. But we know that even though these work, they are not widely available. Yesterday, Hasina was taken to task about the slow availability of these products. So we know that, yes, they are there. We are still rolling them out, they are approved, and we are working on many investigational oral products, topical products, and parenteral products, yes? And we know that a single product or approach cannot stop the epidemic. And our colleagues in the VTN here, they will agree with me when I say that in the long term, we need a safe and efficacious vaccine. Yeah, but it's still years away. And while we are waiting for the vaccine, what can we as the HPTN do? We are working on broadly neutralizing HIV antibodies. And we know that there's a long history. Since 1901, there's a lot of work that has been done in terms of antibodies and infectious diseases. We know Mike on Wednesday, he talked a lot about RSV in pediatrics. I won't go back to that. Recently, we know that malaria can using monoclonal antibodies, and we've just come out of COVID. We know that SARS-CoV-2 can be prevented with monoclonal antibodies. So this is nothing new. But what is new is we in AMP, we showed that yes, HIV can be prevented by monoclonal antibodies. So just to delve a bit into the development of broadly neutralizing antibodies, we know that at HIV acquisition, the red line, the viral replicates very fast and it reaches a peak. So the virus is replicating fast, and as it is replicating fast, the B cell immune responses, they're starting to form anti-GP41, anti-GP20 antibodies. So early on, within a week or two of infection, you start seeing antibody antigen complexes, but these, they do not affect viral load. So they have no effect on viral load. So as that is happening, a few months later, the person who's acquired HIV, they start forming neutralizing antibodies. So about 50% of people develop neutralizing antibodies. The problem with these neutralizing antibodies is that they neutralize yesterday's virus. So these are autologous neutralizing antibodies, but because of the diversity of HIV, by the time you form these antibodies, already the virus is mutated, is diversified. So we tend to say that today's antibodies neutralize yesterday's virus. So they have no effect on contemporaneous viruses. So about 5 to 30% develop what are known as broadly neutralizing antibodies, which come about 2 to 3 years later. And these are seen in about 5 to 30%, and they are broader. Yeah. So in general, I just wanted everyone to appreciate what we mean by neutralizing antibodies, broadly neutralizing antibodies. And we know that bNAbs, they have several advantages over other PrEP products. There isn't the issue about resistance. They could be long acting. I'll talk about this. There's no tail, my friends. There is no tail. There is no pharmacologic tail. We are not in competition. We are complementary. So, and they are safe and toxic. And like I said, we need a vaccine, and bNAbs, they inform vaccine development. I won't spend too much time on AMP. You've heard about AMP. I think AMP is oozing out of our ears. But AMP was a proof of concept, is a proof of concept study which showed that HIV prevention with one bNAb is possible. Yes, the results demonstrated that VRC01 can prevent HIV infection, but that prevention efficacy is dependent on sensitivity of the circulating viruses to VRC01. Yeah, so prevention efficacy was as high as 88% if the virus was sensitive. And the other beauty about AMP is that the study, Gilbert et al., we managed to establish a putative marker of protection, which is known as PT80. So what is PT80? I'm sure we all know about IC80, where we talk about the in vitro, outside the human body, in vitro neutralizing property. So this is IC80. But now we have moved further to talk about PT80. This is in vivo, within the person who's been infused with the antibody, how much neutralization potential. So we are looking at this PT80 to say, if someone attains this level of neutralization potency, then they are going to be protected. So as you can see, we've moved from in vitro to in vivo. That's the beauty about PT80. And we know from AMP, Gilbert et al., they've really worked a lot on this. But the beauty about this is we know that this PT80, in terms of prevention efficacy, there's a sigmoid relationship. As PT80 increases, the prevention efficacy increases. But this has been kept at a PT of 200, which has been shown to have a prevention efficacy of 90%. So when a PT of 200 has been reached, it is anticipated that at least 90% of viruses, if not 100%, will be neutralized. Yeah. So with that, what is the road to combo AMP? I've talked about the genetic diversity of HIV and why there's viral escape mechanisms. Yes. And we know literature shows that resistance to neutralization is attributed to amino acid changes, V1, V2 loop lengths, and additions of glycans. So we know that the next generation of antibodies, they are anticipated to improve efficacy through better coverage, yes, higher potency, yes, and also preventing immune escape. And statistical modeling predicts that second generation bNAbs, especially in combination, they can neutralize up to close to 100% of viruses. Yeah. So what are these next generation broadly neutralizing antibodies? They are more potent, they've got wider breadth. Antibody engineering can increase tissue levels and it extends the half-life. So it means that broadly neutralizing antibodies may be administered less frequently, up to about 6 months. And this is important in HIV vaccine development. So what is one of the ways that broadly neutralizing antibodies have been made more potent? We talk about LS mutations. So to the right is a structure of an antibody, and we know that antibodies are shaped, they've got a Y shape, an FAB part, and an FC part, the bottom, the stalk of the Y. So when mutations, and this stalk of the Y comprises of amino acids. Amino acids are just building blocks. So these amino acids, they can be manipulated, they can be mutant. So when you have, and to date, about 5 mutants have been engineered, and the most common is the LS mutation. So LS just means that 2 amino acids have been mutated. So by so doing, it means the antibody stays longer in the body and it has got a higher concentration. So this is what is shown by the panel at the bottom. For example, VRCO1 LS, it persists in the body for longer. Yes, so that's engineering. And we've now got, and modeling has shown that if we target 3 sites, if we target the CD4 supersite, if we target the V2 glycan and the V3 supersite, if you get antibodies that target those 3 sites, you are more likely to succeed. And this follows the theoretical antibody combinations that we are going to be using for pre-exposure prophylaxis, looking at VRCO7 523LS, PGT121, PGDM 1400. If you look at the heat map at the top, the more blue there is in the heat map, it means that there are more antibodies which haven't been neutralized. So the aim is to have as little blue as possible. So if you look at the bottom panel, you'll see that there's very little blue when we combine VRCO7, PGT121. So you see that's the aim. We need to have as little blue as possible. So this is a possible a combination for pre-exposure prophylaxis. So this just shows what happens. I'm going to cut it. It shows what happens when you have, this is the slide that we used for AMP when we had 1 monoclonal antibody. You see that there is some neutralization. But now when you add these engineered antibodies, the binding, the neutralization becomes more robust. Yeah, it's going to come just now. So these are the 4 possible antibodies that we can use in various combinations. So when we use these, it shows that we target the 3 sites that I talked about, CD4, V2, and V3, and these antibodies are stronger in neutralization. Yeah. So with that in mind, there are many clinical trials that are happening in HIV uninfected adults. And I'm happy to see that we've got protocol team members. Just yesterday, I was talking to Philip, Andrew, as we hear they are doing training for HPTN 109, and I'm hoping you guys are going to start soon. We've done HPTN 101, HPTN 103, and there are many which are in the pipeline. So as you can see in this table here, in this diagram, it's a multicolored diagram. We see that the font, if the font is red, you'll see that HVTN 703, for example, we used 1 antibody. But if it's blue, this light blue, it's a combination antibody. So this is where the 101s, 105s, 109s, they come in. So these are the phase 1 studies which are currently ongoing. And these phase 1 studies are going to inform us how best to do a phase 2 to 3 combo triple AMP. So this is where we are headed. So please watch this space. And before I finish, I'll just refer you to a beautiful piece by Linda Stranix, Shirley. We've got Yvette here. They talked about antibodies for HIV prevention. What is the way forward? They talked about the cost. They talked about how to administer it. So what are the attributes of an optimal bNAb for HIV pre-exposure prophylaxis? It must be safe, it must be highly efficacious, it must be durable and easily administered. We should streamline the supply chain management and the administration. Ngure talked about affordability, scalability, accessibility. We don't need to repeat all that. And most of all, it should have a high genetic barrier for viral resistance, and it must have a safety profile compared to the small molecules that I talked about earlier on. Is it safer than the small molecules? So those are the attributes of an optimal bNAb for HIV as we move forward. So in summary, the future of bNAb research. This is an exciting time, really. The bNAb prevention field is evolving faster than ever. But what has been said, especially Hasina and Saika, they talked about this earlier on. The research, as we do bNAb research, we must reflect diversity, equity, and inclusion, uphold justice and beneficence, and we must target the special populations that we've been talking about, people who use drugs, pregnant and lactating women, key populations, and we begin with the end in mind. What we do in bNAbs must be framed by a human rights-based approach, by Ubuntu, and according to the Aboriginals, we must have respect for all and harm to none. Thank you.
I think we are going to have next the video from Dr. Gesine. Thank you.
On the practicalities of accelerating access to HIV prevention products in the Global South, using the example of I'm Gesine Meyer-Rath from the Health Economics and Epidemiology Research Office at the University of Witwatersrand in South Africa, and I'm presenting on the practicalities of accelerating access to HIV prevention products in the Global South using the example of long-acting injectable cabotegravir. Our key takeaways is that cabotegravir or Cab-A can act as an example of how to set up successful prevention interventions, because it's the first intervention out of a long pipeline of prevention interventions that are coming our way. We also all know that currently the cost of Cab-A is $1,000 per injection, which is way too high for countries in the global south. We know that under the medicines patent pool, a deal has been struck with 3 generic manufacturers, which will reduce the cost in a couple of years' time. But until then, we're stuck with a single manufacturer, which means that in order to scale up rapidly now, we need to do something else that brings down cost. For that, we have to create a big enough market and a rapid enough scale up to achieve 2 joint aims: to have prices be lower because of large volumes and the large impacts that we presented for South Africa to be realized. This very rapid scale up requires a number of factors on both the supply and the demand side. We need on the supply side some rapid interventions in order to reduce the cost. And that could be brought about either by a bind down by donors and or large domestic commitments from countries or governments of countries like South Africa that funds most of its own HIV response from domestic resources, and or additional price reductions to the level of cost of manufacture. We also need every single other thing to happen quite quickly. So we need rapid regulatory approval of the WHO qualification. We need swift integration into national guidelines where required. We need an inclusion of this drug into PEPFAR and Global Fund drug lists. We need manufacturing capacity to be accelerated really rapidly, especially since we only have a single manufacturer, including local manufacture, which is something that the current manufacturer has in fact committed to. And we need to accelerate in-country supply chain management. We have to think about, on the demand side, of targeting additional population groups, including everyone who has a negative HIV test. We need to think about how to make Cab-A happen at the community level, possibly through peer-led care. And we have to consider non-traditional outlets, such as private pharmacies and best practices. The rest of my talk is a summary of a paper that my 2 co-authors and me authored that's come out in the Journal of AIDS at the beginning of the year. Apologies. So our question is, could Cab-A be the game changer that we needed to be? We know that Cab-A has proven effectiveness that is higher than that of circumcision, condoms, and ART, unless there's perfect adherence to the latter. In South Africa, we projected that Cab-A could prevent between 15% and 28% of HIV infections. So that's up here, those scenarios up here, over 20 years, more than any other intervention, including oral PrEP, which is projected down here at much higher levels than it's even currently being demanded. But also any other intervention that our team has evaluated in 7 years of doing annual HIV investment cases for South Africa. And this is over as an HIV program where all other prevention interventions are already routinely offered, and the first and third of the 90 targets have already been met. So we know that there have recently been voluntary licenses to 3 generic manufacturers of Cab-A, which will help reduce costs, but only in a couple of years' time, which is the time period that those manufacturers need to scale up their production. And it's only for countries that are covered by the deal struck by the medicines patent pool, which leaves out a whole number of middle-income countries, in particular outside of Africa, that still have high demand and need for this product. In the meantime, these are the prices we're looking at. So the cost per injection is currently in around about $6,500 in the US, $2,800 in the UK. Those are the only 2 list prices currently available. And for low and middle income countries, there have been a number of exercises ranging from an analysis by the Clinton Health initiative that said it should be possible to produce this drug per injection at between $2 and $3, including capital expenditure. The manufacturer then added that it wouldn't be possible to produce it for much less than $40 to $45. And for South Africa, we did an analysis where we basically looked at the cost effectiveness of Cabalé as compared to oral PrEP and came up with a threshold price of between $9 and $15 per injection for this new drug to be as cost effective as oral PrEP. What happened next, once we had published and publicized this, was that the manufacturer came back to speak directly to this price level to say this threshold price of $9 to $15 significantly underestimates the cost of manufacture, which, in case we didn't know, is more expensive and much harder than for generic oral PrEP, which is a simple white tablet. What happened then is that South Africa got offered a special price, which is exactly the $45 or 35 pounds that the manufacturer had half a year before starting those negotiations already mentioned as being their preferred price for low and middle income countries. And as you can see, it's actually the upper limit of that offered price range. So basically, this analysis did not change the needle. But we are still hopeful in terms of the negotiations still underway between the South African government and the manufacturer. So if this is true, if in fact this drug cannot be produced for anything cheaper than $45, we need for the next couple of years a couple of interventions from outside actors. There's a possibility of a buy down by donors to reduce the cost to a level that's acceptable to the South African government or any other large government that will be in a position to commit to creating demand of a large enough cohort to basically then bring down the price for other countries. This buy down there's an example for that. It has happened before in the production of HIV self-test kits, where there was a large buy down commitment by the Bill and Melinda Gates Foundation that allowed a number of African countries access to millions of self-test kits at very favorable prices. Then secondly, a government like the South African government could fund a large rollout program and further drive down and lock in a lower price level for the rest of the country, for the rest of the world, in fact. And this has happened before, twice, in fact. South Africa committed to a large MTB with expert test program and drove down the global cost of those cartridges for the rest of the world, as well as the cost of HIV viral load tests. However, this is much harder to follow for the South African government at this stage because there is depleted fiscal space after COVID-19, just like in any other country, but much more severe so in a middle-income country like South Africa. And what this means is this is the result of the most current HIV investment case that we've just completed. Here's our baseline, the red, basically the cost of the South African HIV program in billions of rand here. This is our budget constraint for the next 3 years. And for the first time since we've started doing this roughly 10 years ago, this budget will not increase. It will actually flatline. And this is the committed budget from all sources, including the South African government that carries a lion's share, so around 70% of this budget, as well as PEPFAR and the Global Fund. So this means, and here in yellow is a scenario that includes a lot of Cabalé over this scenario, which only includes oral PrEP, that for firstly, supplying Cabalé to everyone who would benefit from it, including large parts of young people, would increase the cost of the South African HIV program by about 40% per year, but will not be affordable under the current budget. So then if a commitment by a large domestic payer like South Africa is not a possibility, then the next option is to reduce the price to the cost of production, and that must be lower than $45. On the additional supply side issues are that this is where pace is really crucial, both for cost and for the import peg, is that all the other factors basically need to fall in place all at the same time. So we need rapid regulatory approval in the countries that are interested in purchasing Caballet. We also need speedy WHO pre-qualification for those countries that do not have their own regulatory authorities. We need swift integration of Caballet into national guidelines where appropriate, and of course we cannot set the standards for other countries there. We need the drug to be included into PEPFAR and Global Fund drug lists, which again allow those countries to access them much more quickly and spend the money. PEPFAR and Global Fund funds on it. We need to upscale large enough manufacturing capacity, and this is a statement we made about a year ago when it wasn't clear that the single monopolist manufacturer would have these large problems with manufacturing in time and building out this capacity, but it really is quite urgent. And of course, that could include local manufacturer, like in a number of countries on the African continent, something that the manufacturer has already committed to, at least in theory. And we have to also build up in-country supply management. On the demand side, it's important to remember again from the South African perspective that South Africa has the world's largest cohort of people, not only on antiretroviral treatment that we know, but also that have tried out oral PrEP and then mostly abandoned it. And just to kind of bear in mind, this is the map of the oral PrEP access from the AGYW website from August 2023. Down here is South Africa, the darkest country. China has no data, so that's the black one, but the darkest country is basically the highest scale here. We have globally around about 5 million PrEP initiations so far. No one is counting the people remaining on PrEP for a number of reasons. And about 18% or almost a fifth of that are resident in South Africa. So that is the country that's pushing PrEP the hardest. But we need to do much better with injectable PrEP. We need to learn those lessons from the oral PrEP rollout. We are doing well with putting people on PrEP. We've been doing this for about 5 or 6 years and have recently accelerated, but we are really, really, really bad at keeping them on PrEP for as long as they need it. So for Caballet, strong demand has been documented, but it is mostly documented in South Africa for those who are either already on oral PrEP or are considering it. We need to access a lot of completely different population groups in order to get demand high enough for both the prices to fall and those huge impacts to realize. So on the demand side, we need to target additional population groups. We have to think about heterosexual men as an additional population group, and we essentially have to offer PrEP to everyone who tests HIV negative at a facility. Now that is of course the original intention, but we have absolutely no systems that make sure that people have at least a conversation about PrEP before they leave that facility or that interaction with the community health worker. Optimally, PrEP provision is community-based and peer-led at the PHC level, at the lowest, using low staff cadres, possibly using deltoid rather than luteal injections. And where possible, we should work towards being able to extend the dosing interval away from even the 2 months to larger, longer intervals. And wherever possible, and this is an example that is very successful of a Thai peer-led key population based PrEP clinic. That's an example of a non-traditional outlet. It might not always look as cozy and well decorated as here, but basically thinking outside of the box and bringing this injectable drug closer to the end user and making it as easy as possible to access it. Thank you very much. That's my summary done. There's a number of funders who have supported the underlying analytical work. Thank you very much.
Let's move on to our last speaker. Thank you.
Is it ready?
The screen to the left is not working.
There we go. Morning, everyone. So I'm just going to talk about firstly our methodology from Community Media Trust. Can you see it? Oh, there we go. Okay, hi, I think we're up and running now. I'm going to talk a little bit today about mass media and social media and the impact of in public health. So Community Media Trust is a not-for-profit communications company, and our job is basically to take all of this research and evidence that you guys have been talking about for the last few days and turn it into communication and language that people can understand and relate to. And we do that using mass comm, social media, outdoor media, any kind of branding and brand development that can reach the communities that we're trying to speak to. So today I'm talking about social listening. So when we have misinformation on social media and how we react to that and use it either to our advantage or respond, and also content creation and high segmentation of target audiences. So our methodology is to use audience participation in everything that we do, from testing and development, brand, color, look and feel, and then test that with the target audience and use it to monitor as we work in mass media, so that we make sure that the audience is understanding the messaging and that they can relate to the look and feel. So we use a lot of popular culture. Instead of trying to create new brands that we think people will relate to, we try to find things that they already relate to and slot our messaging into that. And then we also use multiple channels. So TV, radio, digital, print, everything. So what you see in your popular culture space is also what you see in your community at the facility. People are branded with what they've already seen on TV and what they've already heard on radio. And this is just some of the brands that we've done for different target audiences. So this was for over 35-year-olds, which is a target audience that we often forget about, or that's not as well funded. And it dealt with you. Oh, is it better? Okay, sorry. And it dealt with U equals U, adherence and treatment mainly, Seto. And then another one, this is for VMMC, and this was for target audience, young men aged 18 to 35 for HIV prevention. And this used spinning cars, we played pool, we did all sorts of things that we knew young men were already doing. And then we just worked circumcision into it, which is, it's not an easy thing to do. I never thought I'd be spinning a car for, to cut penises, but here we go. And then Shop, which is our flagship brand, is Siyangoba, which was the brand that was working around getting ARVs available in the public health sector in South Africa. And this is mainly in the Eastern Cape, in facility, and also dealing with age 15 to 35, but it's a very broad brand and works with people living with HIV are in the forefront of it. So all the people in the pictures, all the people on television and radio are living with HIV, and they sort of represent how to live positively. So the Kip is, do you know that colorful popcorn that you get in with street vendors? That's called the Kip. So this brand was developed specifically for young women and girls aged 15 to 24 in 5 health districts, which were randomly chosen. It's a study by Johns Hopkins University. And we worked with the target audiences, young women and girls and female sex workers specifically. And we worked with them to come up with a new way to talk about PrEP, because people don't know what PrEP is. We know because we're doing the research, but they came up with the Kip, which is you pop it, if you pop the pill once a day, you keep HIV away, which is very cute. I mean, I love this brand. Sorry, I didn't know that was going to happen. This is the look and feel. And everything was tested with the target audience and with healthcare workers in facility. So that was the secondary target audience to really understand. And there was a lot of discrimination happening with young women around PrEP, about why they wanted, who they're having sex with. And it turned out to look like something, I don't know, bubble gummy that you you want to have in your life, and we turned it into a lifestyle rather than a pill. Just doing it again. And we also used, we segmented the target audience by using different colors. So we didn't use social media for sex workers. We only used WhatsApp. And we didn't want to stigmatize the young women and girls by mixing up the two target audiences so that they feel like PrEP is for sex workers and now they feel discriminated against, and it's, you know, it's a taboo job. So we separated the brand with colors. And this is some of the...
We vibing. She takes Lekip every day to prevent HIV. It keeps me safe too. Lekip. Take it once a day to prevent HIV. Talk to us on WhatsApp or on Facebook at @le_Kip.
Oh.
We're vibing. I take Lekip every day to prevent HIV. It's free, safe, and easy, and it protects me from HIV. Lekip. Take it once a day to prevent HIV. Talk to us on WhatsApp or on Facebook at @le_Kip.
So we used a different narration under the same PSA, basically from a different point of view with a different character looking to camera, so that we could segment the women from the men in relationships, because obviously we can't, people are having sex together, so we can't just deal with one population group. So that's just an example of how we used the segmentation. This was done in multiple languages, I think six local languages. So the narration would change depending on where we were playing, and the language would change depending on what target audience we were using. And this was only for social media, but I mean, obviously it could be for TV as well, but we were mainly making it for phones. And this is just some of the, so this is, because it's a study, we don't, it actually ends tomorrow. We don't have any final data on the uptake in the districts that we were in, but we do have the social media data. You can see that we started in November last year, November 2022, yeah, last year. The Facebook, and that was from scratch, it was 0 followers. And then this is what the numbers are at the moment. You can see Instagram is a lot lower because I think it's data heavy. So we do struggle with people having access to data. And then we also have everything that's created on all campaigns has a unique WhatsApp number so that people can ask questions one-on-one. It's a direct line. It's like a hotline or a helpline. And we manage that in multiple languages and answer people's questions. So we do a frequently asked questions bi-weekly so that we can also see if people are asking the wrong question, then we know the messaging is not working, right? But we can see from this campaign that most people were asking about what is PrEP. That was the first thing, because it's on the, so Lekip, even though we tried to change the name and make it user-friendly, at least people were still asking, what is it and how does it work? And that's just, we can see by each district where we got the most interactions. And this is also solely based on data availability. So we saw the most interactions on campuses where people had access to Wi-Fi. Oh, and that was just our best performing post. So the couple thing really worked. We had lots of content with just women in it showing, you know, like female power, but this is the one, and that same ad that I just showed you, those are the ones that performed the best. It got the most interactions, both from women and men, but showing people together worked better than showing them alone. And then the other campaign is, this is a COVID based. So Zwakala was to increase the uptake of the COVID vaccine for age 18 to 34. And this was the last age group to get the rollout because we did a staggered rollout of the vaccine. So they were already hesitant about the vaccine and they already felt that we're young and we're probably going to make it anyway, even if we get COVID. So it was a hard target audience to deal with. And again, we used audience participation. We met with them. We figured out what's popular, what looks good, and how do we sort of interact with what young people are already doing or that particular target audience. And this was a national campaign. And then there was a technical working group with the Department of Health, which is made up of multiple NGOs and NDOH, which was doing a monitoring of social media and mass media around the COVID vaccine, which we got a weekly update on to see what are the main sort of misinformation that people are talking about. What are the reasons, the barriers that they don't want the vaccine? And then we focused on the ones that were specifically in this target audience. And then by the time we started off using champions, real people, showing people getting the vaccine. And for a while that was working. And then it just flopped completely because everybody was tired of lockdown, COVID, vaccines, health. Nobody wanted, especially this target audience. So we switched and we took the myths that we found in the social media and the social listening weekly reports, and we turned it into ads. So we sort of flipped them. And the main ones were, we don't know what's in it, like we don't know what's in the vaccine, and it's not safe. And then the last one was about boosting, like why should we bother getting a booster? We've already had the vaccine, we're not interested anymore. So these are some of the ads that we made.
Have you been vaccinated? I don't know what's in it. Have you been vaccinated yet? I don't know what's in it. Yes. Are you still not vaccinated? I don't know what's in it. Immunization is a part of life.
Right. It's the government.
Yeah, that works. And this. Safety, it's a part of life. So get boosted today. It's free.
And every ad that was created also had posters, IC material, T-shirts, bucket hats, branding that people could use and identify with. These are actors though, so everything was scripted. So we switched tactic completely from using real people to using professionals and just turning and using humor rather than facts about stories.
Wouldn't go outside in the rain. Pop an umbrella, would you? Or go for a run with one shoe. You wouldn't use half a blanket to keep you warm, would you? So when it comes to something as important as your health, choose full cover and get the best protection there is. So get boosted today. It's free.
It's just all the material. And then, so this material, we bought space on other platforms like TikTok and Instagram and Facebook, News24, wherever we could find our target audience sitting. And it worked very well. TikTok was huge. The thing is that we can't tell whether it's how long people looked at it or whether it landed or not, but the reach was massive. And the target audience 18 to 35 was watching the videos over and over or more than once. So somehow the funniness of it was reaching the target audience better than the facts. I mean, we'd need a proper interactive survey to understand whether it landed or not, but we were getting way more interaction than we did before. And then, yeah, that's just some of the results. So also, while everything was on mass media and on social media with Swakala, we also had people in, we had screenings in communities. So there would be a film screening, you get popcorn and you get your vaccination and watch like an old movie with Sunshine Cinema. But the people that were drawing the community in were also branded with with Swakala, so they knew from their phones to the community interaction, there was like a brand identification around the vaccine. And that's just some of the data about how it reached. And our viewing rate, you can see there on digital, was 92%, according to what we paid for and what we got, which is, it's very high. So we had a very high rate of interaction around this content. And that's me. I have 56 seconds.
Thank you. Thank you very much for all the speakers. Everybody kept beautifully on time. I'm hearing an echo. I'll try again. Thank you very much, all the speakers, for keeping time. I think we have Gesine with us as well. So this is fantastic. I see one microphone down that way. Is there another one there as well? And another one there, yes. So if people can go to the microphone and line up, we'll try to take as many questions as possible. And the more it's a question rather than a statement, that'd be fantastic. Okay, Mike. Go ahead. I can hear you. Yeah. Yes. I can hear you. Yeah. I can hear you. Yes, she is. She can hear you.
Is this working now?
Yes, yes.
You may, so Dr. That was first, thanks all the speakers. Those were really interesting presentations and amusing under under some circumstances. So my question is about modeling. Modeling is math and assumptions, and I'm very curious about the model, very provocative model presented by Dr. Meyer-Rath, about two questions. What was assumed about tenofovir persistence going forward? Because of course, if the model, I'm sure, had fall off of tenofovir, I just don't know how rapid or how low it got. And then the second question is kind of related. It's about cases of, we know from the work of our colleagues, the cabotegravir table, as it's called, we know from that work that there's a really large difference in the number of cases between cabo and tenofovir, largely ascribed to fall off. But every case that occurs, every event, has then associated with it acute infection with an unknown but substantial number of other transmission events possible. Those are very expensive. So if you don't take into consideration the averted transmission events, then the drug looks more expensive than it actually is in the real world. And it's very hard to model. So I'm just curious whether those were assumed.
Okay.
Thanks.
Thank you. I think we're going to try to take 3 questions and then get to answers, so we'll be very efficient. I see Nero there. Please go ahead, Nero.
Hi, thank you for all very good, excellent presentations. My question is to Nyaradzo. You mentioned PT80 and IC80. How much of that PT80 is really modeling? I mean, is somebody actually measuring those maps in the body, or is it based on modeling? And then why is that important?
Great.
Just to explain the surrogate endpoint part.
Thank you. I have a question actually, which is links to Mike's question, and that's to you, Lucille, is I saw that a lot of your PrEP social media pieces are talking more about letting people know about PrEP and starting PrEP. And we know that in South Africa, a lot of people have started PrEP, and the challenge is really persistence on PrEP. And it seems to me there's a disconnect, like a lot of the social media is about, it's not focusing really on you have to stay on PrEP. So I'm wondering if there's a need to shift. Maybe it's a question whether there's been a shift in terms of what we're trying to transmit, which is not just here's what PrEP does, but stay on PrEP. So that's a question for you. Okay, we have 3 questions already. Yeah, I know, I'm trying to take 3 at a time. So Gesine, somewhere you're up there, can you, did you hear Mike's question? You want to address the issue about the assumptions for the modeling?
Yeah, thank you very much. So Mike, excellent questions, both of them. We only alluded, in fact, to the results of our modeling. We didn't go into any details on the methods because it was really mostly about the practicalities here. But just to get very, very quickly summarize it, there's a paper out in Lancet HIV from, I think, December last year. Lisa Jamieson is the first author who did the modeling that has all the details. But just to summarize quickly, what we did there was compare the scale up of KLA as well as kind of a maximum scale up of oral PrEP using tenofovir-based oral PrEP over a baseline of the South African HIV program, in which, of course, we already have those 800,000 people having initiated oral PrEP. So it's basically a comparison of either we kind of add additional people on KLA, or we kind of max out to a threshold oral PrEP take up. And then the point is that we look at both the cost and the impact over that kind of baseline, which means we have in the model that we're using, the Tembisa HIV model, a full estimation of averted HIV transmissions, etc., over 20 years. So that's why we basically look at the cost effectiveness of each of those scenarios. And in this case, we kind of solve this this kind of ISA equation to then give us the perfect price, the threshold price for injectable PrEP. And that's how we landed with that number. You can do it with any ISA. It's just most of the time we don't do it, but it's of course a much more important number than a cost per daily averted, to be quite frank. And just to kind of go back to the duration question, so our assumption there was that for oral, we assume 5 months on PrEP for non-MSM kind of populations, which is the majority of them, and 11 months for MSM populations. For KLA, we tested a number of scenarios. One was the same duration, and the others had longer duration, as well as, of course, all of them had the higher effectiveness that we know to be true from the HPTN trials. Thank you.
So thank you, Niru, for that question. So before I started my presentation, I should have reminded everyone that I'll do the presentation, and Mike, who's busy chatting with Ken, and Hugh will take the questions. So yeah, but I'll also call on Hugh to come on to PT80 and even Mike. So when we talk about biomarkers, just maybe in PT80, yeah. So PT80, this is it's a prediction, it's a modeling which Nonom, Kise, Gilbert, and them, they worked on this, and it's a neutralization potency. So this is the antibody, the amount of neutralization in a person serum, and this is anticipated to prevent HIV. So Deborah talked about design of studies on day one. And most of our studies, you know, that we are looking at, these are endpoint driven studies. And in HIV prevention, we are looking at HIV acquisition as an endpoint. So when you look at, and thanks to our friends here, we've got a very effective comparator, which is CAB-LA. So in that case, it means people are not likely to seroconvert. So you are going to have to wait long for HIV, which is good. So you are not going to be able to get HIV endpoints. But with this putative biomarker, you can see that, and it's a positive endpoint. You know, we are not waiting for someone to get HIV, but what we're saying is if they reach this neutralization potency, then they are likely to be prevented from getting HIV. So it is a potential endpoint biomarker, and it also benchmarks the effectiveness of vaccine. But I see the giants who Mike are here.
I think unless somebody wants to add something to Nyaradzo's superb answer, we'll go to the next question.
I agree with your answer. I just would say that the studies that the group are doing, that the samples you're collecting are being used to actually measure the concentration of antibodies over time through very accurate assays. And so the PT80 is not really modeled, it's rather measured. So all the AMP, this is for the AMP people, not the cabotegravir people. All those AMP isolates you collected have become the collection that's being used for testing, because that's a recent test. Those are recent. So all of that fits into what Nyaradzo said, where we have the actual amount. In our phase 1 studies, you'll actually measure how much antibody there's in month 1, month 2, month 3, month 4. We'll measure HIV, and we have the HIV pool variants, and we can see the probability that we'll achieve 90% suppression. And if we don't, that'll be a problem.
Okay, thank you. I think maybe I'll go back to Lucille if you can respond to the third question. Thank you.
I think that the aim of Lekipkip was to turn it into a lifestyle issue rather than a health one. So we were trying to create awareness about the fact that you can control your sex life. So a lot of the messaging was about what PrEP can do for you. There is definitely messaging about staying on it, similar to the other campaigns, Adherence, U=U, that kind of messaging sort of, it is there, but it comes a bit later. Your initial interaction with the campaign is a lifestyle-based one.
Yeah, I guess my suggestion is, just having watched a few, is that it'd be helpful if it's, I agree with you on the lifestyle, but to link it a little bit more, maybe more explicitly to ongoing behavior. Yeah, thank you, but thank you very much. Let's take 3 more questions, please.
Hi, can you? Yeah, just a quick question to Gesine, whether the manufacturers, the generic manufacturers broke down their $45 cost a little bit. And I just wonder, is that all the compound that costs so much to manufacture? I'm sure the vialing is all fine. And then a quick question to the Matrix team. You've got a hell of a lot of products potentially coming through. How are you going to deliver this in clinical trials within the 5 years? Thank you.
Not yet. Yeah. Okay, I think again, quick questions and quick answers so we can take as many as possible. Please, next question.
So I want to poke the bear or the panel a little bit. In the 2017 survey data from South Africa shows that there are about 230,000 new infections in 2017. How many people are currently on oral PrEP, and how high should those numbers actually be? And when we bring more tools online, how are we going to ramp this up? Because we have effective tools that aren't reaching the people. Cabotegravir, very, very promising, but how do we break this sort of, we're stuck.
Yeah.
In a way.
Okay, so you're talking about how do we get these products to the people who need them, and I guess that's part of what we've been meeting here about, is to develop concepts to see how we can do that better.
No, I agree. It's a complex situation. So my one question is how many people should we actually have on PrEP?
So that gets at the modeling. I think that maybe Gesine can answer that question. Other questions? I had a question also for you, Dr. Ngure, I noticed that the M in matrix is a microbicide, but you're looking also at non-topical agents. So I'm just curious, like, what's the mandate for matrix? Is it only topical agents, or does it extend to also other agents? And very quickly to you as well, how do you see the intersection between what matrix is doing and the mission of the HPTN? So that might be helpful. Okay, let's start with first question.
Okay, thank you for those questions. I agree the non-products are many products, and the key issue is it's not all products. We are hopeful and we are optimistic that all products will go to clinical trials, but at this point, I don't want to kill your enthusiasm. It may be possible that maybe not all will go to clinical trials. Secondly, is that we have already 3 trials beginning later this year or the first quarter of 2024. The other products should be starting soon. And then our mandate within Matrix is not only on microbicides, so it's still focusing on microbicides and very innovative microbicides, but we're also moving into products that are longer acting, like the carb pellets, the carb hydrogel injectable. So we have extended that mandate. And more importantly is, and that's why I'm happy to present here, is as Matrix, as we continue doing these placebo trials and phase 1 trials, we are looking into aligning with, for example, HPTN to take over from phase 2 to phase 3, and that those are areas that the leadership of the two networks could look into.
Sorry, could I just add on, in terms of matrix, you know that the dapivirine vaginal ring works, and Matrix is now working on a 30-day film. We know that dapivirine works, but the ring has come with its own issues like disposal, for example. So now the beauty about the film, for example, is that it's going to be dissolvable. So now it's just a delivery mechanism. We know that dapivirine works, but what if we infuse it? So there are more products which are more likely to succeed. Of course, like any drug development program, we are going to lose a lot of products on the way, but I'm hoping that there will be some successful candidates that will hand over, and that's where the intersection between Matrix and HPTN, and I'm happy to be sitting right in that intersection. Thank you.
It's wonderful, thank you. I think we want Gesine, I think there was a question like, can you estimate how much coverage by PrEP is needed in South Africa to be able to decrease the numbers of new infections?
Yeah, so there were actually two questions, but I'll answer that first. So as I said, we don't know how many people are on PrEP in South Africa or anywhere else in the world. We know how many people have ever started on it. And there's a good reason to believe that we're actually double counting. So if you're going on and off, starting again, you're probably counting twice. So that's where we have those almost 900,000 people ever having basically PrEP initiations, some of which might be in the same people. We know from our modeling, so our kind of maximum Kabbalah scenarios where we're giving it to large chunks of MSM female sex workers, as well as adolescent girls and young women, so up to 18% of adolescent girls and young women and larger proportions of those other groups. We think we should be having between 1.6 and 3.3 million people on PrEP in any given year. So that's over the next couple of years. And then, of course, the numbers come down over time as the transmission impact starts to take hold. That's really important. And this is where we see two things happen. We do have a net gigantic impact on incidence in South Africa. So we are reducing incidence by up to 23% if we had that many people on PrEP. And because that market would be so huge, it would help gigantically to make the case to, at that stage, probably the generic manufacturers to keep lowering the price for still to have the to still get the same profit out of it, right? So many more people, lower price, you get the same profit out of it. I also wanted to very quickly respond to the first question about the price level that the generic companies should be basically working towards. So those $45 is the upper limit of the current manufacturer. I don't want to mention it, but we all know who is manufacturing Kabbalah at the moment. It's a monopolist price. It's what the single manufacturer says they can't get cheaper or get below. It's important to take that into account and to take that seriously, but it's not what we or anyone else thinks some generic companies will be asking for, because in all likelihood, they will be undercutting that price as soon as they have production ramped up, which will take 3 to 4 years, optimistically speaking. And in terms of what that price should be, well, Chai has gone out and done exactly that calculation in terms of the cost of production. They think it should be between $2 and $3 per injection, not 45. Thanks.
I think it demonstrates the challenges ahead in terms of the pricing, and also very interestingly, this concept of as you use it more, that would hopefully drive the price down for South Africa and for other countries as well. Thank you. Any other last questions? Great. Well, I want to thank all of our speakers for excellent presentations, and thank you all for your questions and your attention. Thank you.
Good morning, everyone. We are on our last plenary session. And as good as all our plenary sessions have been, our next session is the highlight of this meeting because we have our international scholars going to present their work. As many of you know, HPTN has had a very successful scholars program started in 2010 that we expanded in 2015 to the international setting. And we have 3 very good scholars who are going to present today. So I introduce to you Kudzai Hlahla, who is the 2022 International Scholar. She's a pharmacist of record at the Spillhouse Clinical Research Site in Harare, Zimbabwe. And her research interests include the epidemiology of infectious diseases, including HIV in women, adolescents, and young girls in sub-Saharan Africa. And she's passionate about contributing to the body of information and informing policy. I'm going to introduce all of them as Wafa did, and then they can come up, and then we will take questions, similar to how the morning session went. Dr. Victoria Ndyanabangi is a 2022 international scholar, a study medical officer at the Baylor, Uganda Clinical Research Site in Kampala, Uganda, and is also the PI of an couple of impact studies. And Dr. Phionah Kibalama Semambo is a 2023, so the most recent international scholar, is a lead researcher at Makerere University JHU Research Collaboration in Kampala, Uganda. She has also worked on many NIH trials and in the perinatal research space and has worked with MTN-042 and MTN-043. So I welcome all 3 scholars and let's look forward to their presentations.
All right, good morning, everyone. It's difficult to come after Lekip, but I'm going to try and draw your attention back to this scholars project that I've been working on for almost 18 months now. As mentioned, my name is Kudzai Hlahla. I'm from the Spillhouse CRS, and my project was basically focused on the association between substance use and PrEP adherence in adolescent girls and young women that were enrolled in the HPTN OH2 study. Key takeaway points would be that we did find quite a high prevalence of both hazardous drinking and substance use in this cohort, and it was associated with poor PrEP adherence amongst these young women. And we recommend and strongly feel that formative work is required in order to determine facilitators and drivers of hazardous drinking and substance use in this at-risk population. And then that formative research would definitely inform the integration of screening for hazardous drinking and substance use in HIV prevention programs that we've been speaking about for the past couple of days. So I won't labor on this slide because there was a great presentation yesterday regarding the epidemiology of substance use in Africa. And I guess the key takeaway points is that it is a growing public health concern globally and in our setting, predominantly with the use of alcohol, cannabis, and amphetamines. And as mentioned yesterday, heroin is definitely coming up the ladder there with quite scary numbers being quoted regarding the prevalence, especially amongst young adolescents and young people, with a prediction of an almost 40% increase in substance use on the continent by 2030. And why this is of importance to us is in the HIV prevention arena is because what we do know is that substance use results in medication non-adherence. And as we've spoke about over and over again in the past couple of days, this is essential, especially for the use of oral pre-exposure prophylaxis, with studies showing clear dose-response relationships between protection and adherence. This is not a new topic that's been investigated. It's been investigated in various communities, people who inject drugs, gay and bisexual men who have sex with men. However, to our knowledge, a study like this has not been done amongst adolescent girls and young women who we do know are disproportionately affected by HIV in our setting, to just determine what is the actual prevalence of hazardous drinking and substance use, and how will that be associated, and how will that affect PrEP uptake, adherence, and persistence in a community where we are pushing for the rollout of PrEP in this community. So that's what our study intended to do. We wanted to determine the prevalence of substance use at baseline and with continued study participation in the 082 cohort, and to determine if there was such an association with PrEP adherence. We used data that we collected from the CASI questionnaires, and we defined hazardous drinking as having an ordered C score of greater or equal to 3. And then we categorized substance use according to frequency of use, that they were asked frequency of use. We took that, categorized that, and our participants as either low users with a frequency score of 0, moderate users between 1 and 10, and then high users with a score that was greater than 10. And our dependent variable was PrEP adherence, which we measured using dry blood spot concentrations that were collected. We did descriptive analysis to determine the prevalence of hazardous alcohol use and substance use in this cohort. And then we Raul conducted repeated measure multinomial regression modeling with the PrEP categorical data in order to determine if there is an association between alcohol and substance use with PrEP adherence. So the next couple of slides will show our results. Our baseline characteristics, we enrolled 427 PrEP acceptors. The majority of them were between the ages of 18 and 21 and at a secondary school education, and they were more or less similarly distributed across the 3 participating sites, which were Spillhouse, Emma, and Ward 21. Now, with regards to the prevalence of alcohol use and substance use at baseline, we found a prevalence of about 37% in this population of hazardous drinking as defined by the ordered C score. And the prevalence was higher in the 2 South African sites compared to the Zimbabwean site. In addition, we found a prevalence of 24% of ever substance use in the past month amongst this cohort, with the prevalence mostly concentrated as moderate substance users. And we did not find any difference in use of a needle across the 3 sites. Then I'll just quickly jump over the slides. The next couple of slides just show that substance use did drop from baseline and then more or less evened out with study participation. The same happened with substance use as well. But what we did find was that we did find quite a significant association between having an audit score that was greater than 3 in this population. So though it showed an 80% increased odds of being a poor adherer if you had an audit score greater than 3, and that we had a 58% increased odds of being a poor PrEP adherer if you were considered a moderate substance user. So as mentioned before, those were our conclusions, and that we did find an association with hazardous drinking, substance use in this particular population. And as mentioned before with the previous speaker yesterday, we definitely do feel there's a gulf on the amount of data regarding substance use in our setting amongst this particular population. And there really needs to be, and I'm happy to see the HPTN championing the move to do formative work in substance use on the continent. And that would then, of course, inform future trial designs and interventions that would be targeted to prevent HIV acquisition in this particular population. I'd like to just thank the network, the scholars program, and my mentors, Dr. Mgodi and Sybil Hosek. Thank you.
Good morning. So I'd like to present my scholar project. I'm an outgoing scholar, just like the previous presenter, Kudzai. So my project was from the HPTN 052 study, and we set out to determine the incidence of risk factors or predictors for the markers of coronary vascular disease in an HIV positive population who either received early or late antiretroviral therapy. And I'll start with a few takeaways. Okay, so Okay, so when we did the analysis, we found that adverse cardiovascular events were uncommon overall, and our population was majorly between 26 to 40 years of age. Dyslipidemia was the most common event that accounted for about 50% of the events, followed by diabetes and hypertension in that order. And these were more predominant in the delayed arm, although it was not significant. And females were more likely than their male counterparts to experience these events. Early initiation of ART was beneficial in reducing the cumulative risk of people living with HIV who develop grade 2 or higher risk of these events. And we advocate for screening and expanded use of statins in routine care, and this should be considered. I'd like to start by appreciating the HPTN Leadership and Scholar Program for providing us with a platform as early career investigators with all the support and resources. We thank our mentors who take out their time to provide guidance and mentorship, because this experience wouldn't be without their support. I'd also like to thank the institutions that gave us the opportunity and continue to provide local support for us to be able to do these projects, and above all, for believing in us. It's been a learning curve and we continue to learn, and it's been an exciting experience for upcoming researchers. So for my project, I worked with a team, my mentor, Professor Mina, who is in the room, and Dr. Maganizo, who are both from the UNC project in Lilongwe, and my statistical support, Ms. Deksha Sharma from SHARP. So as we know, globally, the burden for NCDs accounts for about 71% of 41 million deaths annually. And sub-Saharan Africa is known to have the largest proportion of these. And it's predicted that it will overtake infectious diseases as a major source of morbidity and mortality. HIV per se is a risk for developing coronary vascular disease. And understanding the risk factors for these predictors is critical to mitigating this. Most of us have heard about the REPRIEVE study that has just been concluded, which was a phase 3 multi-site study that revealed that it's beneficial to have pivastatin, which was the study product on this study, as part of prevention for NCDs. So this is something that has been recently published, and we feel that it could be translated into policy. So 052 was a trial that was multi-site as well, and it showed that early initiation of ART reduced acquisition of HIV in the negative partners by 96%, and the health outcomes were favorable. So when there was a DSMB in this trial in April 2011, it was recommended that the delayed arm of this trial should be stopped and everyone initiated on early ART after the benefits that were shown. So our main objectives were to determine the prevalence and incidence of these predictors of coronary vascular disease, and we had a number of variables that we considered. And we were interested particularly in grade 2 or high adverse events pre and post the DSMB meeting. We also wanted to look at the incidence of these risk factors and determine association of age and sex with these factors, as well as determine the cumulative incidence. So our variables of interest were particularly hypertension, diabetes, dyslipidemia, liver or renal disorders, and obesity. So as alluded to earlier, prevalence and incidence, we used the DATES toxicity table, looking at grade 2 or higher events. For prevalence, we looked at from study entry to the DSMB and incidence post the DSMB recommendations, and we excluded those who either did not have an ART start date, terminated prior to the DSMB meeting, or didn't have any of the conditions prior to the DSMB date for the incidence. So we did an event-free survival using Kaplan-Meier, and also calculated time to first occurrence of an NCD event, defining the cutoff point as the DSMB date, and for those who didn't have any at their last visit. It was a randomized trial, so we had an equal proportion of males to females. Majority of our population was between 26 and 40 years, and majority were married. So prevalence, we had 53 for the immediate comparative to 52 in the delayed arm, 7 in the immediate arm at study entry, to DSMB and 10 in the delayed arm, respectively. Incidents, there were only 34 cases with more in the delayed arm, although this was not statistically significant. And when we did the chi-square, we realized that still there were more adverse events in the delayed arm. As alluded to earlier, the primary events or distribution of events was dyslipidemia first, diabetes, and hypertension in that ranking. When we looked at the probability of developing adverse events, it was slightly greater in the delayed ART arm, although it took about 2 or so years for the first grade 2 and above event. In the multivariate analysis, the statistically significant finding was that females had a greater risk or stood a greater risk than their male counterparts. So for future considerations, we would like to say, let's advocate for early initiation of ART because it has been shown to be beneficial in reducing the risk for these events. The prevalence and incidence of these events, though low, it is important to screen for these risk factors, especially at HIV diagnosis, and offer screening services. People living with HIV should be offered the service as part of routine care, and maybe we should consider routine prophylaxis with pivastatin as an expanded service offered during care. I thank you and I acknowledge all the support given to the HPTN network and the HPTN Scholar Program that supports us. Thank you.
Good morning, ladies and gentlemen. The main objective of my project is to explore correlations between contraceptive use and PrEP adherence to inform integrated service delivery among young women in Southern Africa. And this is a secondary analysis. Okay. And this is a secondary analysis from the HPTN 082 study. So highlights from my presentation. We know very well that adolescent girls and young women aged 15 to 24 years in sub-Saharan Africa remain at substantial risk of HIV acquisition and unintended pregnancies. So integrated service delivery models serve as a platform to implement comprehensive, complementary HIV and sexual and reproductive health services for adolescent girls and young women to scale up PrEP. Therefore, targeting adolescent girls and young women seeking PrEP services with contraceptives would provide the dual benefit of averting possible HIV and unintended pregnancies. Just a bit of statistics, UNAIDS fact sheet 2023, 63% of new infections of HIV are mainly in women and young girls. And in 2019, there were 10 million unintended pregnancies annually, especially in this population. So the rationale of my study is that adolescent mothers face higher risks of pregnancy and birth-related complications, and their babies face increased adverse health outcomes. Despite this, contraceptive uptake by this population remains low and inconsistent. And this population experienced multiple sexual and reproductive health issues, therefore making integration and comprehensive HIV and sexual and reproductive health services very critical. And in regards to PrEP, it's known now by 2015, WHO recommended PrEP for people at substantial risk of HIV acquisition. And we know that the proven benefit is that if PrEP is taken adherently, the risk of HIV infection may be significantly reduced. That's making it an important HIV prevention intervention for this population. Therefore, integration of contraceptive services into HIV clinics has led to increased contraceptive use and reduction in unintended pregnancies. This is what we already know. So the aims of my project, I hope to establish the correlation between highly effective contraceptive method use, and in this case, I'm looking at pills, injectables, implants, or IUDs to exclude condoms. And we are looking at these and correlating them with PrEP adherence among young women who participated in this study over a 26-week follow-up period. Also looking at evaluating the association between contraceptive use and PrEP discontinuation, as well as the association between contraceptive switch and PrEP adherence. There's also an exploratory aim where we'll describe associations between any contraceptive use at baseline and transactional sex, relationship dynamics, and condom use among women who are enrolled in the HPTN 082 study. A bit about the analysis plan. We'll apply a random effects ordinal logistic regression, accounting for repeated measurements over time to assess that association that I've already talked about. And in regards to aim 2, we'll create variables in regards to switches, looking at those who remained on the same, those who switched, those who discontinued, creating those groups and looking at how they fared in regards to PrEP adherence. And then the last aim, we'll look at, again, logistic regression. So this is just a slide to show where the study was done, the HPTN 082 study. It was done in Zimbabwe and South Africa. There were 2 sites there. So the current status, since I'm an incoming scholar, I'm at the point where data analysis has begun. So I look forward to learning from this process and knowing the answers to what I've set out to investigate. Okay, and this is just something that Bill Clinton said. We live in a completely interdependent world, which simply means we cannot escape each other. How we respond to AIDS depends in part on whether we understand this interdependence. So therefore, it's not someone else's problem. We're all here and it's our problem. So we need to tackle it together. A bit about my timelines. The award came in through in April 2023, and at the annual meeting, were inaugurated into the program. Between July and September, I've been finalizing the statistical analysis plan and the project proposal, and analysis has now begun, which is going to continue till, I'm imagining, till about February, when I'll possibly have a bit of what results look like. And then I hope that between March and July, I'll have an abstract and be drafting the manuscript. By June, I should present to you results from this project at the annual meeting. And then the program ends in November, where I should have a manuscript by that time. These are my mentors. My main mentor is Professor Jennifer Velosa, who's not present here. My local mentors are Dr. Clemencia, who is our site leader, and Dr. Brenda Gatti-Mirembe, who are in the room. And a statistician is Michael Barton. And at this point, I would also like to acknowledge the support that has been given by Professor Deborah Donnell as we were drafting the analysis plan. I appreciate your support. At this point, I'd like to end my presentation by acknowledging the funders of the HPTN and the Scholar program, as well as my employers who have given me the necessary support. Thank you very much.
Thank you very much for all 3 presentations. It's open, the floor is open for questions. For those of you who want to ask questions, I see Wafa up there. By the time she gets there, just one quick question to Kudzai. I saw that there was a difference between Emma Wunleni and the other sites with respect to alcohol use. I think Emma had more. Is that just random, or is that some sort of, can you explain why there was such a big difference?
Thank you for that question. So we really we can attribute, okay, so participant variability will probably play a really big role in the differences in substance use or alcohol use across the 3 sites. Although the literature does allude to, for example, alcohol use, it's South Africa has been reported to have a higher level of alcohol use compared to other nations, not only in the continent, but globally. So that variability can be accounted by the fact that they're South African sites, but we cannot we cannot say this we cannot say this conclusively, because the participants could have been different just by location and age. University students have different drinking habits compared to probably other populations, but yeah. Thank you.
Wafa.
Yes, thank you very much. Excellent presentations. I have a question regarding the NCD work, which is very interesting. I'm just curious, you found that there was a higher risk amongst women, which is highly unusual. Usually with NCDs, it's likely men, at least most of the studies. So can you hypothesize why that is in your cohort in particular?
It was also an interesting finding for us as well when we did the analysis. However, this was a randomized trial and there was equal proportions of males to females. And what I realized in this study, it wasn't routine data that was picked up. It was on a case-by-case basis. So this information was being picked from the adverse event log as and when clinicians identified the events. So it might be an issue of reporting that maybe if the men came in and didn't report events, they were not picked up. However, we couldn't confirm this. I hope that answers your question.
Nyaradzo.
Thank you all. Excellent presentations, and we see future HPTN leaders in you. My question is to you, Victoria, the NCDs. What was the rationale for reporting? You said you looked at NCDs which needed interventions. Yeah, but what was the rationale of reporting from grade 2 onwards? I didn't take part in HPTN or 5.2, so I don't know whether the grade 1 adverse events were reported. Why I'm asking is that we see in HPTN or 8.4, I see a lot of obesity. And when we talk about NCDs, there are a lot of modifiable risk factors. So whether it's mild, moderate, or severe, we really shouldn't be sort of ignoring, because even if it's moderate or mild, we can do something about it to arrest the propagation or the continuation of the NCDs. So my basic question is, why did you not look at
Who's post DSMB? Why didn't you take the whole sample?
Thank you for that question. We did decide to look at grade 2 or higher adverse events because we were looking at those who required intervention. We were using, of course, the DAIDS table. I know, yes, there were grade 1 events. There were also few, but we wanted to see, since it was subjective to someone reporting symptoms and being managed, how many of these were actually present and required management. And then also, why did we use our cutoff as the DSMB date? The DSMB recommendations recommended that delayed ART should be stopped. So this increased the population on ART, and that would give us a good sample size to look at more people who were on ART and how many of these actually developed these events. So that was the rationale for doing the grade 2 or higher. But yes, there were some grade 1 events.
Could you introduce yourself and answer this question?
Yeah, wonderful presentations. I'm Ali from the UVRI. I'm just wondering, my comment goes to users. Would you comment on the linkage to care for the hazardous alcohol users? Thank you.
Could you repeat the question again, please?
Linkage to care for the hazardous alcohol users. Thank you.
Thank you for that question. And again, that is why we would then definitely advocate for more work to be done in this particular arena. As presented yesterday, with regards to the epidemiology of alcohol and substance use in Africa, most African countries do not have linkage to care for hazardous drinkers or substance users. And there is need to advocate for for more establishments of these, either community-based or private-based, or for those that are private-based, for them to be affordable to people in the general community. Because for those few countries that do have rehabilitation facilities, either for alcohol or substance use, it's not within the the reach of the common man who is being disproportionately affected by substance use and alcohol use. So we need to measure the problem, and then from measuring the problem, create the interventions, and probably from measuring the problem and seeing how great the problem is, that forms a great basis to now start suggesting solutions regarding what do we do with this potentially upcoming epidemic.
Thank you. Are there any other questions? And we're going to look for Phionah's results next year. Before we close, I have one major announcement, and I'm going to call Mike Cohen for closing remarks. Right after this session, please don't disperse. I think Cameron is planning on getting a full group picture. So please just gradually get out of this room and stay right there. And I think someone's going to take a picture from the stairwell so we can capture about 150 people all in one picture. So we'd like to have that, and then we can break for the break. So now I call Dr. Mike Cohen.
Yeah, congratulations to the scholars for the presentations. I will be very brief. I'll say thank yous that would be appropriate, and I'll make just a few observations. Probably the most important thank you. It's been because of COVID and time. This has been several years since we had a chance to be together with our colleagues from 22 sites all across Southern Africa. And so that's a real privilege. And we thank all of you for coming and sharing your ideas and your energy with us and letting us visit you. So that's my first thank you. I want to thank FHI who put together the meeting and made all these logistical contributions. And that was really obviously done very well, since no one's complained about anything. I mean, I cannot believe we've been here for 3 days and no one's complained to me about anything. That's unheard of. And so I really want to thank them. I want to thank the local hosts from Cape Town who helped us so much, and Linda Gale, and Sinead has an apartment here, and others. Really, thank you so much. Most beautiful city in the world, and it's a privilege to be here. So on behalf of WAFNI and the network, I've given these thanks. Let's make a few observations. What is important to me is, after all these years post-COVID, the energy that exists. We heard so many times about people are tired of this and tired of that. Yet at this meeting, what I could see is this real enthusiasm for the work we're doing, and that you're doing, really, and looking forward. And that enthusiasm and energy is borne out in the kind of really very robust discussions that we had at the World Cafe and in all these breakout groups, and people coming, 100 people came to the concept development idea. So these are the things that would allow us to go back to the NIH, who I have to thank excessively because they provide the funds, go back and say, well, there's no less enthusiasm for the work that we're doing in Southern Africa than there was 20 years ago. But we made a lot of progress, but there's more to go. In the universe of the observations beyond the energy, it's pretty clear there's a trajectory, and that trajectory is towards some of the biomedical products. That there's the cabotegravir table, and then the AMP community. They're separated somehow by this wall, but we see the energy towards these biomedical products, and then we see energy that's especially important, and a real commitment to women of childbearing age. We discussed that a lot. To adolescents, we discussed that a lot. To several other priority populations, we discussed that a lot. And then to our aspiration to try and do a thing we haven't really done, and that is link the STD community and expertise with all the HIV expertise that's in this room. It's pretty clear to me, coming really from an STD background, that these silos have not been useful. And one of the network's goals is to try and really, really embrace the opportunity for us to bring these communities together, because the STD problem is not in any way independent of the HIV problem, and the STD problem gets no attention. So that's one of our really high priorities. So in summary, I would say this is the first meeting I've ever attended. It's only 6 minutes late and it's supposed to end at 10:30. It's only 10:36. So I think that's an accomplishment of biblical proportions. So we are going to end this meeting with, once again, really thank you so much for letting us visit and for your enthusiasm and from coming all over Southern Africa to be with us all together as a group. And that will be manifested in one photograph, as I understand it. So we are going to leave, we're going to applaud, leave here and have a photograph.